If you are a medical provider working in resource-limited environments, then really you should be using ultrasound. In this video series that is and will remain completely free, I'm going to tell you the why, the where, and hopefully give you some knowledge to help you upskill in this area. My name is Chris, I'm a critical care doctor, and I also work as a medical director for a humanitarian foundation called the Team 5 Medical Foundation, where we travel into remote settings to provide healthcare for people who have often never seen a health provider in their whole life. I also wrote this textbook called Ultrasound for the Generalists with an aim to provide any clinician with the information they need to use ultrasound in their own environment. Please remember that ultrasound does not belong to any one specialty, job title or role. Anyone working as a medical provider is perfectly capable of doing this, be they a doctor, a medic, a PA, a nurse, a physio, a midwife, the list goes on. Don't feel that your job role limits your ability to use this in your own area. Anyone who works in the field, be that expedition medicine, humanitarian disaster medicine, pre-hospital emergency medicine, event medicine, they're always going to be resource limited. The utility of one of these is at the best of times pretty limited. So by adding in the use of this, you're going to be dramatically increasing your diagnostic potential for your patients. Ultrasounds used to be huge, expensive machines that clearly is not appropriate when you have to carry all your stuff into the wilderness. But nowadays, some of them are massively cheaper, smaller, lighter, and can plug straight into your phone or tablet. This one, the Butterfly IQ, is probably the cheapest and most popular one at the moment. However, there are lots of different options available, including from Philips, GE, Clarius, and Echonaus. You can often just use a single probe nowadays for pathology affecting the heart, the lungs, the abdomen, brain, the eyes, women's health, including obstetrics, and increasingly now for use in research. The more information you have in these settings allows you to be more precise with your diagnoses and allows you to accurately triage those who can maybe stay or those who need to be evacuated for higher level care. Essentially, the more remote and resource limited your setting is, the greater the value that you'll find from using point of care ultrasound, or POCUS. Whatever your office looks like, be it the Central American jungle, the Sahara Desert, the mountains of Nepal, or even fixed-wing aircraft in the middle of Australia, ultrasound can play a role for you. One of the reasons for doing this video series is a lack of resources dedicated to people like you working in these environments. But remember that you are your own clinical correlation, and just like with many other elements of your day job, you can extrapolate knowledge about ultrasound in one area into your own setting. One key principle though is to remember that you are a clinician first. POCUS should add to and not replace your conventional history and examination, and only once you developed a differential diagnosis should you start to use ultrasound. We are answering targeted questions and not trying to do a full system interrogation. So let's think about an example scenario now. You're an expedition medic on a mountain hike at around 4,000 to 5,000 meters, or that's 13,000 to 16,000 feet for you Americans out there. You have a team member who has a cough, he's a little short of breath, and he's generally just worried. You're in your tent examining him. It's already dark and it's way too windy to be using a stethoscope. So what's the diagnosis? Well, they could just be short of breath because they're at altitude like everyone else. They could have picked up an infection prior to their ascent and now developed a lower respiratory tract infection or a pneumonia. They could have had a deep vein thrombosis and a pulmonary embolism given their recent history of long-haul travel. Or could it be what everyone worries about at altitude, that is high-altitude pulmonary edema? Well, ultrasound can actually rapidly answer any of those questions. Consolidation pneumonia has a very characteristic appearance on ultrasound. In its early stages, you just develop these early patches of subpleural consolidation. However, as it progresses and becomes more severe, you may develop full lobar consolidation, including dynamic air bronchograms. High-altitude pulmonary edema will look completely different, with an interstitial or B-line profile with all these comet tail artifacts coming down from the pleural line. In thromboembolic disease, the lung may look normal, but you can look at the groin to identify a deep vein thrombosis, or at the heart to identify a dilated right ventricle or interventricular septal flattening, as is seen in a large pulmonary embolism. Or are the heart and the lungs normal? Don't be deflated about this, a normal finding is just as important as finding pathology because it enables you to exclude these things that you're worried about. Anyway, more of each of these findings later in the series. Clearly, you've made it this far in this video because you're interested in using this in your practice. I'm hoping that these videos will give you a bit more of an introductory insight into how to do it. However, there are loads of resources out there for free if you just look for it. All you need to do is Google or put into YouTube POCUS and you'll have loads of resources available. Admittedly, most of these are for hospital-based settings, particularly emergency medicine, but it will give you a good grounding in the knowledge that you need to apply this to your own setting. I do recommend going on a course if you can. This will give you hands-on training with an expert who can give you pointers where needed. This course doesn't necessarily need to be dedicated to austere medicine. There aren't many of those about at all, unfortunately. But there are plenty of courses available for emergency medicine and for critical care, and these will give you a great grounding that you can extrapolate to your world. After this, you really just need to practice. The more you do, the better you'll get. Having a supervisor to do one-on-one scans with is obviously an optimal situation. However, it's not feasible for most of us. And even when I was learning in an emergency medicine and a critical care setting, I didn't even get that. The best thing to do is try to find a supervisor in your general area who can help you and provide you with remote supervision. This is something I've done a lot of using online platforms, video calls, and online image review. I feel very passionate that this is something that can be done just with remote supervision if you're willing to dedicate the time yourself. If this is something you're struggling with, need help, or just need some general advice, then please don't hesitate to leave a comment or email me directly. The next video of the series is going to cover some basic principles of ultrasound before moving on to the more interesting stuff, including ultrasound of the heart, the lungs, the abdomen, vasculature, the eye, the brain, and anything else you might want to cover. If there is something that you want me to cover in the future, then please just leave a comment below. See you then.